everyone, and welcome to another episode of Arthritis at Home. My name is Ellen, and today we are joined by Dr. Keith Colaco. He is an assistant professor of teaching at the University of Toronto, and Keith's PhD work focused on chronic disease and exploring new methods to predict a person's risk of developing cardiovascular disease in future. And more recent work has focused on the field of cardio-rheumatology, which we will get into shortly. And with that, I want to thank you for joining us today, Keith.
Great, thanks, Ellen. Thanks for having me.
So Keith, can you tell us a little bit about yourself and how you're involved in rheumatology?
Sure. So currently, as you mentioned, I'm a faculty member in the Department of Health and Society at the University of Toronto, where I teach undergraduate students, but I also collaborate with various groups on research projects. And I got into it actually by kind of a bit of luck and happenstance when I just finished my undergraduate studies and I started a job in research at Women's College Hospital in Toronto. And my research job was actually focused in rheumatology. So I was a research coordinator. My supervisor was a rheumatologist, and that's how I kind of fell in love with the field and learning more about psoriatic arthritis specifically, which led me to pursue a PhD shortly after that.
It's so interesting to hear all the trainee stories because there is so much serendipity, right? Like, how did we get here? There's so much serendipity in our stories, for sure. And Keith, I know that you've specialized in a specific field within, not rheumatology broadly. Rheumatology, for simplicity's sake, we'll say, anything to do with the joints, broadly speaking, and sometimes not even the joints, right? Because rheumatology also encompasses gout as well. So with that, Keith, can you tell us what cardio-rheumatology is? I think it's, two words mashed into one, but please explain.
Yes, absolutely. So I mentioned that prior to my PhD, I was focused more on psoriatic arthritis, and I was working under the supervision of Dr. Leahy Etter, who's also based at the University of Toronto. And as I started learning more about these inflammatory diseases like psoriatic arthritis, I was introduced to this field of cardio-rheumatology. And I like to think of this as sort of a sub-discipline within rheumatology that's very collaborative, and that also tries to increase and heighten awareness about cardiovascular diseases in people living with rheumatic conditions. So this field came to be because we, over a period of years, learned that people with inflammatory arthritis, like psoriatic arthritis, rheumatoid arthritis, lupus, and several other rheumatic conditions, they have an increased risk of developing cardiovascular diseases, including heart attacks and strokes. So this field of cardio-rheumatology, just imagine cardio-rheumatology, or we call it cardio-rheum for short, a lot of words in here. So cardio-rheum kind of is bringing together not just rheumatologists, but patients and other people who are involved in their care. So if we think about cardiovascular diseases, now it's including cardiologists and it's including family physicians into the ball, because we know that there's a lot to manage here and there's a lot to talk about. So this is why I call cardio-rheum as collaborative and helping to push further education about these conditions.
Very interesting. And this sub-discipline, we can call it, is a combination, if I'm hearing you correctly, of cardio as in like cardiovascular, as in like heart health, right? Yeah. And then rheumatology. So you're really looking at the intersection of, if someone is living with, for example, a type of inflammatory arthritis, and you're seeing this association of higher risk of cardiovascular disease or complications. And Keith, can you, share with us perhaps one of the projects that you're currently working on that is related to cardio-rheumatology?
Sure. So I can maybe expand more on this intersection between cardiovascular disease and rheumatic conditions. So we all know that inflammation is just bad for our bodies. So it's not only bad for our joints, right, and our connective tissue, for example, but we know that this inflammation also affects the blood vessels and can damage it. It can cause a condition called atherosclerosis, which is essentially a buildup of plaque in the blood vessels that can cause blockages and lead to a heart attack if it's occurring in the heart, or, for example, a stroke if it's occurring in the brain. So a lot of the research that I've been working on with Dr. Leahy Etter and others at Women's College Hospital have tried to kind of investigate this association between this development of plaques and also heart attacks and strokes. So if I can maybe share one project that we recently published, it was part of my PhD, so it was published about a year ago. We were basically trying to look at ways we can predict someone's risk of developing a cardiovascular event in the future using existing information in the present. So there was various ways we kind of embarked on the study. We were just looking at very basic information. So we called these traditional cardiovascular risk factors. So think about simple things that your doctor can tell you that can tell you about your risk. So for example, your age, your sex, if you're male or female, if you're a smoker, if you have diabetes. So we used information like that to predict future risk. And we also tried to see, is there anything specific to someone's disease? And we focused more on psoriatic arthritis. So we looked at a group of over 1,000 patients with psoriatic arthritis. And we tried to see, like, is there something that a rheumatologist collects in the clinic that's specific to their disease? So for example, if they have really swollen or tender joints, if they have really severe psoriasis on their skin, can we use this disease-specific information in addition to their traditional cardiovascular risk factors as like a combined, what I like to call it a risk calculator that can help to predict future risk? When I say future, I'm saying like 5 to 10 years into the future, it'll spurt out a value like, 70% risk of developing a heart attack or stroke. So that's essentially what the study was. And what we found was that a lot of this disease-specific information didn't really add much value to traditional cardiovascular risk factors. So that's basically saying that these simple measures like age, sex, diabetes, hypertension are also just very powerful indicators of future cardiovascular risk. And what we really need to do as patients, healthcare providers, et cetera, is talk more about it and better control these risk factors. So we really don't need to get too fancy. The basics are good, is what the data told us right now.
Which is great. Simple,
Yeah.
simple is better. And I want to go back to two things that you said, Keith. So number one, this inflammation is the new word, or it has been the hot topic for a couple of years now. And the concept of is inflammation kind of one of the underlying factors of most, if not all, chronic conditions, or at least somehow one of the drivers of progression in chronic disease. And so what you're telling us is that inflammation in this case may, in one hand, be associated with an individual's arthritis, as well as maybe a driving factor in their heart health of any sort, and maybe contributing to that plaque buildup that you were mentioning. So it's really interesting how perhaps, again, we don't know for sure, or maybe we do, that there's this one cause or one factor that has multiple influences on the human body.
Yeah, correct. Absolutely. And, one example is this is happening very slowly and it's progressive over several years or even decades. So people aren't aware that it's occurring, right? So for example, we know that inflammation can also change the cholesterol profile in your blood. So elevating those bad cholesterol particles and reducing the good cholesterol, for example. So that's just one way inflammation can have an impact on your cardiovascular profile over the long term.
And then so interesting that we can calculate, right? Like we are able to have a reasonable predictor, and I use the word reasonable very broadly, predictor with certain factors like diabetes, like lifestyle factors, to calculate our risk. And for those individuals who are like, that sounds strange, like how does this work? I know this has actually been done in the field of osteoporosis, where you can actually, it's been around for, I believe, 2 decades, where you can get a score, right? You put in a few details about yourself and you're able to get a score. And am I correct to say like this operates in the same way? You put in a few details about your health, about your lifestyle factors, and you're able to get some sort of score, which is a risk score, a 10-year risk score.
Yeah, absolutely. So a lot of these risk scores or risk calculators have been developed. They're not new. They've been around for decades now. And for example, like the one you mentioned is specific to people with osteoporosis, you were saying, right? In general, a lot of these risk scores have been developed with general population, so people without specific diseases. So the whole objective of our group was to develop a risk score specific to people with psoriatic arthritis. That's what has not been done before. And there's also been some literature, for example, of other research groups who have tried to develop these risk scores for people with rheumatoid arthritis. So this is something that's very new in rheumatology, is developing these disease-specific cardiovascular risk scores and seeing if they're better than these general risk scores that were developed for everyone, regardless of disease.
And you were mentioning, Keith, that it doesn't seem like our disease-specific indicators, like how swollen my joints out, how high this antibody is in my blood test, that doesn't really seem to have an effect on the risk score.
Yeah, it doesn't seem to, what I say, has an additive effect, like a beneficial effect above the traditional cardiovascular risk factors. That's what we're looking for, because we know that they work really well, but we're looking to see if something can be added to it to improve it further. And the analysis didn't really show us that it did.
Which means, does that mean, in this case, Keith, that the traditional calculators for cardiovascular risk score are actually pretty good for individuals with psoriatic arthritis?
Yes, absolutely. Yeah.
Well, that's really exciting to know. And do you have some resources to share with us, perhaps?
Absolutely. So, this whole field of cardio-rheum has spurred a lot of people, including the groups I work with, to develop a lot of resources. Now we have these specific cardio-rheumatology clinics. So, for example, we have one here at Women's College Hospital that is directed by Dr. Leahy Eder, who's a rheumatologist, like I mentioned, and Dr. Paula Harvey. She's a cardiologist. So they work together. And they see patients who are referred from their rheumatologist directly to here for specialized care. So one way to get more information, I think, is to visit our website. I'll get you, Ellen, to link it. It's called cardiorheum.org. It's basically our website across the University of Toronto, and you have more information about our clinic. And also there's a section on patient resources. So we have dedicated resources for patients with rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis that are seen in the clinic that can learn more about the link between cardiovascular disease and their disease, and also how to get care from the program.
Thank you for sharing those with us. And we will definitely link them for our audience, and hopefully for individuals like myself in BC, those will be helpful as well. And Keith, I do want to ask a question. So if I'm a patient living with arthritis and I have family history of cardiovascular disease, and obviously, like, you are on the cutting edge of this research, and this is not something that's, so to say, common practice. Is it worth bringing up with a GP? Is it worth bringing up with someone like it? As a patient, I also want everyone to have, like a learning, like, what are they taking away from this conversation of, like, yeah, you need to vocalize this to your GP, to your rheumatologist, who may not know of this research quite yet.
Yes, thank you so much for bringing up. It's very important that patients do take charge of their care and bring these concerns forward, even if they're not sure what it might mean for their overall health. One thing that's come up recently in Cardio-Rheum, and my colleagues have published an excellent article about it online. It's basically called Cardio-Rheumatology, it's time to collaborate, is really having these conversations across disciplines. So for example, having patients bring it up to their GPs, these concerns, and having that be communicated to the rheumatologist or even a cardiologist if they're being involved in the larger circle of care. Because oftentimes, a lot of the time spent in clinic is really they're focused on the patient's rheumatic disease, right? That alone takes a lot of time. And often there isn't enough time to talk about these other concerns like their heart health. So it's really important that we start the conversation, and maybe a rheumatologist might be the one who takes the lead and actually looks at your cardiovascular risk factors and then brings that back to your GP, from those latest blood tests. But if we don't really speak up about it, we can't start focusing on these issues. So absolutely, I'm glad you brought it up, and it's something that we're trying to push for more disciplines to focus on, because there's just a lot going on already with people's diseases and the issues they're living with.
I think it requires all of us to be aware, and also to all of us to advocate, right? Whether we are a patient, clinician, a researcher, a policymaker, healthcare provider, that this is an important issue, and that it's about time. It's about time we all talk to each other.
Yes, absolutely.
With that, Keith, I want to thank you for your time. I know you're incredibly busy, especially preparing for courses. For everyone who's watching, we will link all those resources below, so you will have access to them. And with that, thank you so much for joining us, Keith. Thank you for joining us, the audience, and we hope you all learned something new today. Have a great rest of your week.
Great. Thank you.